Good morning. Today's topic of discussion would be on orofacial pain. Now, one of the most common reason for a patient to visit a dental surgeon or a dentist would be the dental pain. The Greek word pain literally means penalty or punishment from God. So, the definition of pain goes like this. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such a damage. So it's an unpleasant sensory as well as an emotional component is attached to this experience. Okay, so this is the definition which is given by the International Association for the Study of Pain. Now the question arises, is pain necessary? Why do we feel the sensation of pain? The sensation of pain gives you conscious awareness of tissue damage. Otherwise, imagine if there is no sensation of pain, the tissue damage would be unabated. So, therefore, it helps to protect your body or the structure. It removes from the danger, promotes healing as well as avoids further noxious stimuli. It also elicits a behavioral as well as emotional response. Now, whenever there is a noxious stimuli to the in the skin or mucosa due to trauma or injury or mechanical breach, there will be release of certain inflammatory mediators such as serotonin, bradykinin, prostaglandins. So these will in turn they'll stimulate the free nerve endings which are present in that area, which carry these nociceptive signals to the next level. So the impulses are transmitted to the spinal cord by two types of nerves from the orofacial region. One is the myelinated A delta nerves which carry the fast pain, and the unmyelinated C nerves which carry the slow pain. These impulses ascend to the somatosensory cortex via two pathways, the spinothalamic pathway and the reticular formation. So the pain from the orofacial region is mainly carried to the sensory cortex through the trigeminal nerve. Okay, so these branches then they ascend to the higher centers and elicit as pain. So pain is not perceived until the pain signals reach this higher center in the brain. If pain signals are thereby prevented from reaching the cortex, the pain may not be felt by the person. So whenever we come across the patient with the complaint of pain in the orofacial region, the approach to diagnosis depends on a detailed clinical history, clinical examination, thorough clinical examination of the individual. Of course, because pain has a psychological component associated with it, a psychological evaluation, and followed by the diagnostic tests which may be required to arrive to a proper diagnosis that may include chairside, laboratory or radiological investigations. As far as history is concerned, when we record the chief complaint of the patient or the history of present illness, the duration of the pain, the onset of the pain and the progress of the pain, in short what we can call as OPD, should be recorded in detail, along with the location, the nature of the pain, whether the pain is intermittent, continuous, whether the pain is shooting type, burning type, pricking type, and what is the intensity of the pain, okay, whether it's moderate, severe or mild pain. Along with this, any aggravating factors, by doing what activities the pain gets aggravated and by doing what activities the pain gets relieved. So relieving as well as aggravating factors should be recorded. Now, along with this detailed history of evaluation of pain, one can also follow this PQRST format, which is be easier for you to remember. Now, what provokes the pain? P stands for provocation. What provokes the pain or what activity increases or decreases the pain? What is the quality of the pain? Pain is, as I said before, burning type, sharp pain, radiating pain, Whether it is a referral pain or a radiating pain. A referral pain is site distant to damaged tissue that does not follow the course of a peripheral nerve, while as radiating is follows the peripheral nerve. How is the severity of the pain? How bad is the pain? You can measure this with the help of a pain scale. And also the timing of the pain. When does the pain occurs? Whether it's night time or daytime, and whether it is affecting the activity of the patient. Okay, so these are the PQRST format one can also follow. Measuring of the pain can be done with the help of visual analog scale, although we cannot exactly, because pain is more of a subjective, it cannot be objective. So if you want to make it objective, then we can use this visual analog scale where the pain severity is measured from 0 to 10 on a scale. 0 indicates no pain at all, as well as 10 indicates severe pain. So you can ask your patient to locate the number based on the nature of the pain. Measuring of the pain can also be done, which is more elaborative way of evaluating the pain using the McGill pain questionnaire, which evaluates the sensory as well as other subcategories of pain. It's all the components of the pain are considered in this approach. When coming to arriving to a diagnosis for the cause of orofacial pain, one must remember there are two types of body structures. One is neurogenic structures, which includes your brain and spinal cord, peripheral nervous system, and autonomic nervous system. Another is the somatic structures. Soma means organs, skin and mucosa, musculoskeletal as well as visceral organs. These are the somatic structures. So if you go through the textbook of oral medicine, you will come to know that the pain has been classified, orofacial pain especially has been classified into two axes. One is axis 1, which is physical conditions causing pain. Axis 2 is the psychological conditions causing pain. Axis 1 is further subdivided into, as we have studied before, whether it is originating from the somatic structures or neurogenic structures. The somatic structures could be originating from skin, mucosa, musculoskeletal, that is TMJ, okay, while as neurogenic would be the one which are originating from the neurogenic structures. Okay. Axis 2 would be more of a psychological, that is mood and anxiety disorders. For a simplified way of classifying pain also we can come across. The clinician must carefully evaluate both the axes here, both the axis 1 as well as the axis 2 in order to arrive to a proper diagnosis. So as I said, to make it more simplified, we can also classify pain, the causes of pain originating from orofacial region into odontogenic and non-odontogenic. Odontogenic means originating from teeth, basically. So that could be pulpal origin, periapical, periodontal, pericoronal, a cracked tooth syndrome causing pain, or a dry socket. These are the most common reasons for pain originating from odontogenic structures. Whereas in non-odontogenic, that is apart from tooth, there could be myofascial pain, pain originating from TMJ, sinusitis, pain originating from paranasal sinuses, salivary gland origin, neuralgias such as trigeminal neuralgia, glossopharyngeal neuralgias, postherpetic neuralgias. Vascular reasons of orofacial pain could be migraine, cluster headache, and neuropathic could be atypical odontalgia, burning mouth syndrome, and lastly the psychogenic causes of pain. So these are the non-odontogenic causes of pain. Going one by one, now first let's understand the odontogenic causes of pain. In most common cause of odontogenic cause for orofacial pain is, as you all know, is pulpitis. Inflammation of the pulp. It presents as an acute, sharp, severe, throbbing kind of pain which radiates and is non-localizing. The pain aggravates on taking hot or cold or on lying down. Okay, this is a typical presentation of pulpitis pain. Clinically, one may examine that there is a caries of the tooth, or a restoration, or a fracture, or discoloration of the tooth. Typically, the pain is non-localizable, so there would be no tenderness on palpation. Radiograph would only reveal presence or absence of one of these clinical pathologies. So the radiographs are not diagnostic for pulpitis, it's more of a clinical diagnosis based on the history and examination. Coming to periodontitis pain, the pain of periodontitis as compared to pulpitis, it is dull in nature. It is mild, not as severe as pulpitis pain, mild to moderate. It's aching type of a pain, and it can be localized because of inflammation of the periodontium. So it aggravates, the pain aggravates on pressure or while chewing. That is the typical presentation of periodontitis pain. Clinically, one may find there is a periodontal inflammation, that is presence of a pocket, recession or mobility of the tooth. Radiograph may reveal early changes, may not be detectable on radiograph. However, there could be, if it is advanced, there could be mild to moderate bone loss that may be associated with the involved tooth. Coming to the next common cause of orofacial pain, which is odontogenic, is apical periodontitis. It is presentation of apical periodontitis, which is a sequelae of pulpitis, is similar to pulpitis. Differentiation would be that here, since the infection or inflammation has reached the apical areas, the pain becomes localized. While as in pulpitis, the pain was more of a non-localized radiating type of a pain. Clinically, again, one may come across caries, restoration, fracture, discolored tooth, and typically the involved tooth would be tender on palpation. Radiograph would reveal the presence of pathology in the crown along with the widening of the periodontal ligament space. Coming to pericoronitis, which is seen with the eruption of a third molar tooth. Usually the pericoronal inflammation will present with a dull, mild to moderate aching pain which is localized to the area, and it aggravates while chewing or on pressure. There would be inflammation of the pericoronal tissue covering the partially erupted tooth, and radiograph would reveal there is an impacted tooth in that area. Now, cracked tooth syndrome is not a common cause of orofacial pain. However, one needs to rule out this condition when there is an incomplete fracture of a vital posterior tooth that involves the dentine and occasionally may also extend up to the pulp. So this crack in the tooth may not be visible clinically, but it presents as a pain on biting and release of the bite. That is the typical presentation of pain along with thermal sensitivities. So as I said, since it is very difficult to detect the crack clinically, it is better to use transillumination or bite test whenever you come across such kind of cases. Radiograph, again, if the crack is not complete, it's rare to be detected radiographically. Sometimes the CBCT would be more conclusive in such cases. So as you can see in this image, a CBCT which is showing that there is a crack running across with the 2-7 tooth, which is visible very clearly when we take a CBCT of such patients. Now coming to the non-odontogenic causes of the pain. Among non-odontogenic causes, myofascial pain is the most common cause of non-odontogenic cause of pain. In this, there will be regional unilateral dull aching pain, typically located along the region of the body of the mandible or on angle of the mandible or around the ear and temporal region. The pain is more localized and there will be tender spots that in the masticatory region when we palpate the muscles, especially the masseter, the temporalis, and the TMJ and jaw movements are usually not affected if it is purely myofascial pain. Unilateral chewing phenomena is a very common history which can be elicited from these patients with myofascial pain. The radiograph do not have any role because since it is a muscular pain, there is no role of radiographs in diagnosis of myofascial pain. It's purely a clinical diagnosis. The management would be reassurance of the patient. Use of NSAIDs and muscle relaxants can also be utilized in order to relieve the severity of the pain. There is a role of TENS therapy and hot and cold therapy in such patients. along with relief of any high points that are, if they are present, occlusal corrections, and bilateral chewing with soft diet for few days. Coming to myofascial pain dysfunction syndrome, as you can see, we have added two words to it, to myofascial pain, that is dysfunction syndrome. Here, there will again be same regional unilateral dull aching pain, typically in the region of the body and the angle of the mandible or around the ear. But clinically, when you see, there will, along with the tender areas of masticatory region, the TMJ will also be tender on palpation or on movements, and there will be limitation of the jaw movements. Sometimes there will be deviation of the jaw towards the affected side and inability to perform the lateral excursions of the mandible. So this is, along with muscular pain, there is presence of TMJ dysfunction. That is why the condition is also known as myofascial pain dysfunction syndrome. The unilateral chewing habit or the occlusal disturbances or the history of bruxism, one has to rule out in such cases. Radiograph usually do not have any major role to play here in this condition as well. Management is similar to myofascial pain, that is reassurance, NSAIDs and muscle relaxants, TENS therapy. If there is any occlusal disturbances, one needs to address this along with use of soft occlusal splints if the patient is having night grinding or bruxism habit. When we deal with patients with myofascial pain or myofascial pain dysfunction syndrome, one needs to take a history of any orthodontic treatment in the past, restorations, prosthesis, unilateral chewing habit, history of stress, subluxation or trauma. Clinically, one needs to look for any eccentric contacts, high points, adhesion facets, and missing teeth or pathological migration of teeth due to which the patient is having unilateral chewing habit. Among the non-odontogenic causes, TMJ pain is one of the major contributory. In the TMJ disorders, the capsulitis and synovitis, arthritis, disc derangement and displacements are the common reasons for pain. Capsulitis and synovitis presents with painful joint basically, which is exacerbated on movements. The loading and palpation of the joint from lateral or via external auditory meatus, there would be feeling of pain for the patient. Usually follows external trauma or intrinsic strains injuring the capsule or the synovium. Synovitis also presents with swelling. There will be mild edema and swelling over the joint areas, especially on the lateral side of the joint. Clinically, these won't present with any joint sounds and there won't be any radiographic findings because this is of a soft tissue. In such cases, MRI would be of some use to evaluate sinusitis and capsulitis. Osteoarthritis. In arthritis, osteoarthritis is an extremely variable clinical presentation. Sometimes there would be no symptoms, while sometimes the patient will be having severe pain and dysfunction with extensive radiographic changes that may be visible on the radiograph TMJ. Pain and joint dysfunction is in some patients with minimal radiographic evidence also can be we can come across. The hallmark of this condition is restricted range of movements, deviation of the joint towards the affected side, and crepitus joint sounds while making the movement, opening and closing movements. The radiograph would reveal, as you can see in these radiographs, there will be narrowing of the joint space. So if the disease is advanced, then one can even find erosions of the joint surfaces as well as formation of osteophytes or elysis. Coming to the next condition, that is articular disc displacements. Then when there is a disc, the disc in the joint is displaced anteriorly, medially, anteromedially or posteriorly, very rarely posteriorly. In this, usually it is the disc displacements are either with reduction or without reduction. What do we mean by with reduction? With reduction means the disc is displaced, however the person is able to move the mandible to its normal opening position. There will be clicking while opening as well as while closing because the condyle has to overcome the displaced disc. So there will be reciprocal click while opening and closing. Mild to moderate pain while opening the jaw. unrestricted mouth opening as I said before, and deviation of the jaw. This is with reduction. Without reduction means the displaced disc is obstructing the complete opening, where there will be absence of a click or a reciprocal click. The pain would be little more moderate to severe with restricted mouth opening. The mouth opening would be less than 35 millimeters along with deviation to the affected side. So this is the articular disc displacements. Because of the pressure on the inflamed area, the patient will experience pain while opening and closing. And as you can see, with reduction, the patient is opening is not affected, while as without reduction of the disc, there is a locking, and as a result, the patient is unable to open the mouth completely. So when we deal with these kind of disorders, especially the temporomandibular joint disorders, the thorough counseling of the patient has to be done along with the soft diet for a few days or weeks, restricted mouth opening, use of non-steroidal anti-inflammatory medicines and muscle relaxants if pain is in very moderate to severe, hot and cold therapy, short wave diathermy, occlusal splints are also useful in these disorders. Now cases requiring arthrocentesis or intra-articular steroid injections can be considered if the pain is not relieved by other measures. Yeah. So the neuralgia pain is usually more sharp and intense. Okay. And usually the common cause that has to be ruled out is neurovascular compression. Other reasons would be multiple sclerosis also. The combination of drug therapy is used to treat these neuralgias. The carbamazepine is the drug of the choice and also a diagnostic drug, you can say, along with oxcarbamazepine, baclofen, gabapentin and pregabalin. These are the drugs that can be used for treatment of neuralgias, especially trigeminal neuralgia. Surgical treatment would be recommended when the medicinal treatment is not effective for the patient, with the help of Gesserian rhizotomy, decompression of the neurovascular bundle, percutaneous radiofrequency, thermocoagulation and gamma knife radiosurgeries. These are the surgical options to treat neuralgias. Coming to the migrainous headache, which is another reason for non-odontogenic cause of pain. It's a unilateral headache which is moderate to severe. And usually these pains are also accompanied by pulsations in that region. So it's pulsating, lasts for few hours to few days sometimes, accompanied with photophobia, nausea, vomiting and nasal congestion. A common trigger for migraine would be stress, hunger, alcohol, the bright light. So these patients avoid going out to sunlight. Okay. So when there is a migraine attack, the abortive measures would be use of NSAIDs or ergotamines, and even triptans can also be useful, especially sumatriptan can be used in the treatment of migrainous attacks. As a preventive medicines, we can use beta blockers like propranolol or calcium channel blockers like nifedipine. Tricyclic antidepressants like amitriptyline can also be used as preventive medicines. Coming to the next category of disorders, that is cluster headache. It presents as a unilateral, deep, excruciating pain attack, which is explosive in nature. So you should know that these kind of pain, when they present, they are very severe, and it presents typically in and around the eye or temporal region. So some even report a sensation of stabbing or ice pick-like pains in periorbital regions, which last for up to 30 minutes to 1 hour. So that's the presentation of cluster headache. Typically, attack occurs at the same time in a day. Commonly, time is 1 a.m. or 2 a.m. in the night, waking the patient from the sleep. So, this kind of cluster headaches will affect the sleep pattern of the patients. They are also known as alarm clock headache. This is how we can differentiate cluster headache from neuralgias. The neuralgias usually won't affect the sleep of the patients. Now, the cluster headache is also accompanied by ipsilateral tearing, rhinorrhea as well as ptosis. To abort the attack of cluster headache, one has to use 100% oxygen inhalation for 5 to 10 liters per minute. The drug of choice to abort the attack would be sumatriptan 6 to 12 milligrams along with ergotamine inhalations. As a preventive, one can use oral ergotamines, verapamil as well as prednisolone in this condition. Atypical odontalgia is a very rare phenomenon. It presents as a constant dull pain in the orofacial region with no apparent cause. It occurs mostly in females, 4 to 5 decades of life. There would be no other changes, no thermal sensitivity, no trigger zones. So the site of the pain also would not be constant. Patient presents with pain in one area, while as in next visit he or she may say that the pain is now in different area. So repeated dental therapy failed to resolve these kind of pains. So diagnosis would be a challenge. Usually these patients need a psychological thorough counseling along with tricyclic antidepressants such as amitriptyline, which is given at bedtime for these patients. Burning mouth syndrome is again a rare condition in which the patient experiences burning sensation of at least 4 to 6 months duration located on the tongue or other mucosal membranes in the absence of any clinical or laboratory changes. So here also something similar to atypical odontalgia, there would be no physically, clinically evident changes in the oral cavity. Frequent site of this pain is anterior 2/3 of the tongue. So there is a possible association of anxiety, depression, and in this sense because this condition is most commonly seen in postmenopausal women. So one has to rule out local as well as systemic causes of burning mouth syndrome, such as any ulcerations or anemic changes in order to arrive to a diagnosis of burning mouth syndrome. So reassurance along with drugs such as antidepressants, antipsychotics, even the role of alpha lipoic acid has also been very encouraging in treating these patients. So with this we come to the end of today's discussion on orofacial pain. So we have to take home few points from today's discussion. That is, one is that the pulpitis is the most common cause of orofacial pain, especially the odontogenic cause, and it is very severe and non-localizing pain. Periodontitis pain is usually dull and localized as compared to pulpitis. Myofascial pain is the most common non-odontogenic cause of pain. TMJ pain is also associated commonly with restricted jaw movements. Neuralgias are usually paroxysmal, intermittent, stabbing or lasting for few seconds with sleep undisturbed. Migraine pain is pulsatile, unilateral, associated with nausea and photophobia. And atypical odontalgia and burning mouth syndromes do not show any clinical or radiological evidence of the disease. With this, we'll come to the end of this session. One has to remember that the bird in the lawn is more likely to be a sparrow than an eagle. There is a famous saying. So one needs to exclude common dental or oral causes first before thinking of unusual, uncommon, non-dental or extraoral causes of orofacial pain. Thank you. If any questions are there, you can ask.